We're delighted that you can join us on the National Fuld Institute for Evidence-Based Practice webinar series. Today I have with me Dr. Cindy Zellefrow. Cindy is Director of the Academic Core within the National Fuld Institute. We have other cores within the Institute. We have a clinical core that is directed by Lynn Gallagher, who also serves as Senior Director to the Fuld. We have a translation research core that is directed by Dr. Sharon Tucker. And we also have a consumer core, which we are building out now. And really, we will be working hard to bring the best evidence to consumers, along with clinicians, the C-suite, and other healthcare providers, as well as academicians. We have a philosophy in the Fuld Institute, and that is that in God we trust. Everyone else must bring data to the table. And we really do live by that philosophy here at The Ohio State University. So if those remember my work in particular, I really started to push very hard this evidence-based practice movement nearly 20 years ago. And I was hoping that by 2020, evidence-based practice would be DNA of every practicing nurse, nurse practitioner, physician, pharmacist, and other healthcare provider throughout the country. Because we all know evidence-based practice will get us to the quadruple aim in healthcare, and that is improving the patient experience, which is high quality care, improving population health outcomes, decreasing costs, and also improving the work life of the clinician. So for several years, almost 2 decades now, our team has done a lot of research on evidence-based practice. What are the barriers? What are the facilitators? What are the best models, not only to advance evidence-based practice, but also to sustain it? And sustainability is a hot buzzword right now because there are a lot of hospitals that work hard to get EBP started, and they get it advanced to a point, and then it doesn't sustain. And in large part, that is because the culture has not been built to the point to make evidence-based practice the default choice within a system. And after Cindy presents the data between magnet and non-designated magnet institutions, I will come back and talk about our research and what we have found to be crucial to not only advancing but sustaining evidence-based practice. So our team, again, has done a lot of research on evidence-based practice. And I want to give a shout out to Kathleen Stevens, because Kathleen first pulled a group of people together to really create the first set of competencies for academic studies and how to prepare students for evidence-based practice, we decided to update and devise a contemporary set of competencies for practicing nurses who are at the bedside, as well as advanced practice nurses. So we pulled a group of 7 national experts together. My colleague Ellen Fine-Out Overholt and I drafted that first set of competencies with a national consensus panel who agreed on them. And then we did research, 2 rounds of a Delphi survey to confirm what these competencies were. So we published our competencies for evidence-based practice in Worldviews on Evidence-Based Nursing in 2014. You can still access those competencies free on the Worldviews website. So after the competencies were developed, we decided to do a national study to see where are nurses throughout the country on the reporting of their own evidence-based practice competencies. We just published this outcome data in Worldviews on Evidence-Based Nursing. Again, the article is there. It can be freely downloaded. The aims of that study were also to determine important factors associated with evidence-based practice competence. We used a cross-sectional anonymous descriptive survey with nurses in 19 hospitals and healthcare systems throughout the United States. Their mean age was 44, 92% were female, 85% were non-Hispanic white, nearly 60% had a bachelor's degree, and almost 70% worked in a magnet-designated organization. So we were optimistic that about half of these folks would report that they were at least competent on half of the evidence-based practice competencies. But as you can see in this particular slide, sadly, the mean competency scores did not reach competence for any of the 13 competencies for bedside nurses, with an additional 11 for advanced practice nurses. Even what was a little bit more disheartening was when we looked at self-reported competency by academic degree. There was a wider spread for master's prepared nurses, as we would expect, bachelor's degree nurses, but the only competency that reached competence was the first one, and that is questioning clinical practices for quality improvement. As you'll see on this slide, there was very little difference between associate degree nurses and bachelor's prepared nurses. And for everybody on the webinar today that teaches at the baccalaureate level, I would so encourage good analysis of how this is being taught because we cannot continue to teach students at the bachelor's, at the master's clinical levels, the rigorous process of how to conduct research. We really must be teaching our students how to use the research evidence being generated by our wonderful PhD researchers, and how to translate that evidence into practice rapidly to improve care and population health outcomes. And I also want to say that there are still many DNP programs throughout the country that are requiring their students to do research as their DNP capstone. That was never the intention of AACN when they really developed the concept of the DNP. DNP should be evidence-based practice experts. Our PhDs should be the rigorous researchers because they have gone through rigorous research coursework and skills building. So we looked at correlations amongst the variables in this national competency study. And as you can see on the slide, competency was related to culture. I have a saying always, and that is culture eats strategy for breakfast, lunch, and dinner. So creating cultures where evidence-based practice is the norm is what needs to happen. You will also see knowledge was linked to competency, but knowledge alone is not the only predictor of competency. Every clinician must have strong beliefs in the value of EBP if they're going to implement that consistently in practice. And as you will see on the slide, the variable that had the strongest positive relationship with competency was that of evidence-based practice mentorship. I will talk again about our ARC model, of which the critical factor for implementation and sustainability is that evidence-based practice mentorship. We have not published, we're getting ready to submit this study for publication. We did structural equation modeling because we wanted to see how all of these variables came together to predict the evidence-based practice competency, EBP implementation, and we also wanted to see what influenced job satisfaction and intent to stay. And as you can see on this slide, an evidence-based practice culture predicts job satisfaction, which then predicts intent to stay. Culture predicts evidence-based practice mentorship, and EBP mentorship is a direct predictor of intent to stay, which is why getting back to having critical masses of evidence-based practice mentors in an institution is so imperative. Culture also predicted clinicians' beliefs about the value of evidence-based practice, which then influenced their level of implementation. Culture also predicted one's knowledge of evidence-based practice, which then predicted competency and then competency predicted evidence-based practice implementation. So that was the national study. So we just completed analyzing, doing secondary data analysis, because what we wanted to tease apart was data to answer this question. Does working at a magnet-designated healthcare organization really make a difference on our variables from this national study? So I'm going to turn it over to Cindy now, who's going to share the data with you on what we found.
All guests have been muted.
Ern, thank you so much. And again, I'm thrilled I am to be here with you today to share this exciting information. Before we dive into the results from the secondary analysis, I'd like to take just a moment to frame a little bit of background information about the Magnet program. Because literally for decades, ANCC and the ANA have been the innovators and visionary about elevating and celebrating nursing excellence and quality of care. The program first was proposed to the board back in 1990 out of a 1983 study done by the American Academy of Nursing, where they identified 14 qualities that high-performing organizations had that really helped recruit and retain well-qualified nurses who promoted quality of care. Over the last almost 30 years now, those 14 qualities that came to initially be known as the focuses of magnetism have continued to evolve. So Magnet really is not an award, but rather it's a recognition. It's a designation that reflects excellence in nursing and in quality of care. As I mentioned, the 14 focuses of magnetism, as the model has continued to evolve, have now become this particular model, the new and innovative model that really, again, continues to focus on that commitment to excellence in nursing. In today's world, nurses really look to hospitals and organizations that are designated as magnet as a sign of their commitment to excellence in nursing and good working environments. Organizations wear that badge of honor and that designation as a source of pride. And in today's competitive market, consumers also look for it, because where excellence in nursing lives, quality care often follows and grows. And the program really has grown. I'd like to thank Rebecca Greystone from ANCC for her collaboration in helping us put this together. And again, as you can see by this particular slide and graph, Magnet continues to grow. As of 2018, almost 8% of hospitals now are proud to bear the designation of having Magnet status. So let's take a look at the graphics, the sample of the Magnet-designated compared to non-designated institutions and the demographics of our participants. So as we look at the slides, you'll see that when we take a look at Magnet-designated organizations compared to non-designated, the number of years that a practitioner has in a current role is just slightly longer in non-designated institutions compared to Magnet-designated. Likewise, number of years in practice, slightly longer in non-designated hospitals and organizations compared to designated hospitals. So not much of a difference. As we continue to look at the roles that the participants in our study had, you'll see obviously the vast number of participants in our study were actually staff nurses. And as we shared with you, we had over 2,300 participants in this study, followed by a mixture of people in convoluted or different types of roles, educators, managers. But what's exciting is that truly all levels of nursing were represented in our sample, from the staff nurse to the CNO and CNE. When we look at the education level of magnet designated compared to non-designated hospitals, again, we'll see that bachelor's prepared nurses lead the way with a close, almost a tie, if you will, between the number of staff who have diploma or associate's degrees and master's degrees or higher within both our magnet designated and non-designated institutions and organizations. And last, in the demographics, we think of interest is the exposure to the concept of evidence-based practice. When we take a look at where people have learned about EBP, we can see that, again, the vast majority of them have learned EBP in nursing school in one form or another, which makes it extremely important, again, that in our academic programs, that we really are teaching evidence-based practice true to what it is, so that, again, we can continue to front-load our organizations with those people who really have a good, sound foundation in EBP. Next most frequent way of getting to evidence-based practice education is taking continuing education course. But if you look, just over 10% in the magnet-designated organizations and closer to 13% in the non-designated are still reporting in this day and age that they really don't know much about EBP. So again, interesting to see in point by point in the demographics just how close designated and non-designated organizations are. But let's jump to what we're really interested in. What is the impact on knowledge, beliefs, competency, culture, implementation, intent to stay, and job satisfaction? We'll start with culture and mentoring because, as Bern has already discussed, culture really is key to implementation and sustainability of evidence-based practice. It eats strategy for breakfast, lunch, and dinner, and it's a strong predictor of many indicators of evidence-based practice, implementation, and sustainability. As we look at on the left-hand side of the bar there, you'll see that the impact, again, of evidence-based practice, of culture on EBP in magnet-designated hospitals is slightly larger than in non-designated. And likewise, on the right side, the presence and the impact of EBP mentoring, again, slightly larger in magnet-designated hospitals compared to non-designated. Now, as we did the statistical analysis, though, one thing that I'd like to mention is that throughout the indicators, as we found some statistical significance on a couple of the slides that we're getting ready to move into, because of the mere size and magnitude of the sample size, we've also looked at clinical significance or effect size. Because remember, with these unusually large sample sizes, you can reach statistical significance even if there's no impact on clinical practice. As far as organizational culture goes, these the findings on organizational culture, align with Wilson's study of 2015, where they did a descriptive cross-sectional survey using the Information Literacy for Evidence-Based Nursing questionnaire. And they too found that in magnet-designated organizations that there were fewer barriers. So again, these findings, although minimal difference, do align with the fact that Wilson also found that there were fewer barriers reported by nurses at magnet-designated institutions and organizations. As Bern said, one of the key things is important to make sure that we're developing that structure to really support evidence-based practice implementation. As we go on to the next slide, for this particular one, we use the Evidence-Based Practice Knowledge Acquisition Questionnaire, or KAQ, a 27-item survey that has been tested for reliability and validity. Across the vast majority of the items on the EBP KAQ, we found no difference between magnet-designated organizations and non-magnet-designated organizations when it came to EDP knowledge. The exceptions are the 6 that you see on the screen. And again, these were the only 6 where there were statistically significant differences among magnet-designated compared to non-magnet-designated indicators. However, when we looked at the clinical significance or the effect size, there was none between them. As Bern had mentioned too, knowledge alone does not drive competency. So in this study, we also used the 24-item evidence-based practice competency questionnaire to see where nurses were self-reporting. And again, as we compared magnet-designated versus non-magnet-designated organizations, we found minimal differences between the two on the competencies. And again, there was only one that had any statistical significance among the 24. However, it too did not show any clinical significance. Next, we've always talked about the importance of belief, because we know that beliefs need to be high in order for people to move into action. And again, on the belief scale, which was a 16-item scale, there were only 3 that showed any difference whatsoever. 1, I believe that EDP is difficult. Second, I am sure that I can access the best resources in order to implement EDP. And third, I believe that EDP takes too much time. Once again, if we take a look at the effect sizes, they are so small that they don't even register on the scale. But I find it interesting that 2 of the 3 say that nurses believed that it was hard and that it took too much time. And again, we know when beliefs are high, implementation often happens. And again, as you can see, once again, we found no differences between magnet-designated and non-magnet-designated organizations. Last, looking at job satisfaction and intent to stay. And again, when we took a look, once again, we found no significant differences between magnet-designated and non-magnet-designated organizations. So in summary, we found little to no differences between magnet-designated and non-magnet-designated organizations from our sample in our study. Now, again, EDP culture, beliefs and competency, and mentoring have slight differences, with culture and mentoring the most significant in the magnet-designated organizations. But as we look at this, we need to keep in mind, again, that just like healthcare is continuing to evolve, so is the magnet designation program. ANCC continues to be committed to quality and excellence in nursing and elevating and celebrating that. The 2019 document is coming out, so many of you who are already working towards that magnet designation have that document. And again, looking for some additional changes. The good news is we now have additional data to bring to the table. So again, letting the evidence guide our journey, there's a new opportunity to be had. So I'm going to go ahead and turn things back over to Bern so she can wrap it up.
So again, we have to understand that evidence-based practice does equal the quadruple aim in healthcare. A couple years ago, we also did a national study with chief nurses, 276 throughout the country in 45 states. What was very interesting in that national study was that, one, the chief nurses said their highest priority was quality and safety, but evidence-based practice fell to the bottom of their priorities. So what they didn't really understand was that evidence-based practice is the direct pathway to get their hospitals and healthcare systems to quality and safety. In other words, to get them to the quadruple aim in healthcare. But think about this. If chief nurses really did not understand that evidence-based practice led directly to quality and safety, they're not going to invest in developing their clinicians and giving them the needed resources and skills to be competent in evidence-based practice. So we really have to devote intense time and resources to chief nurses. Most of those chief nurses in our sample for that national study were in their 50s. They didn't grow up with evidence-based practice. They grew up with the traditional research course in their bachelor's and their master's programs. This is what they told us when we did a follow-up summit with 160 chief nurses. They told us, you have to remember, Bern, we were educated when research was the core of the teaching, not EBP. So we didn't learn the steps. We didn't learn evidence-based quality improvement. So again, this is a huge target to get these chief nurses skilled themselves. So they invest in evidence-based practice in their organizations for their clinicians. So now that we have these contemporary competencies for bedside nurses and advanced practice nurses, we must use them. They need to be integrated in healthcare system orientation programs. When new nurses start, they should be shown these competencies. They should be asked to report on their level of competence. And if they are not competent, we devote the time and the resources to getting them competent in evidence-based practice. We have some healthcare systems that we're working with now that are incorporating these competencies into their clinical ladders and into their performance appraisals. But again, we need to incorporate these into real-world practice settings as well as academic settings, because that is going to achieve quality, safety, improve patient outcomes, as well as decrease costs. And as Cindy and I both talked about, we've got to remember how imperative culture is. As you saw on our structural equation model, culture was driving everything from beliefs to implementation to competency to intent to stay. It is such a critical piece. But we leaders know culture doesn't change overnight. It takes time, 5 years, 7, even 10 to change culture. And there are so many leadership changes anymore that leaders aren't in place long enough to really see that culture shift. So then it doesn't happen, and a new leader comes in with new ideas. So again, culture, we must pay really close attention to building a culture that makes evidence-based practice the foundation, the default choice with all clinicians. This is behavior change for a lot of people because they grew up years ago when maybe they were being taught not rapid critical appraisal, but critique. given an 80-page checklist to dissect a single study, and it took them 2 to 3 weeks. So then they said, this isn't realistic. We as clinicians can't do this in the real world. So I really want everybody to understand this truly is behavior change for a lot of nurses. The average age of a nurse is around 47. So again, they didn't grow up, many of these folks, with evidence-based practice. So faculty as well. Faculty might be fantastic researchers, but maybe they never learned evidence-based practice, rapid critical appraisal skills, evidence-based quality improvement. Faculty cannot teach what they themselves don't know. So we've got to get faculty these skills so they can turn around and teach it to their students. So critical components of an evidence-based practice culture that we have found through our research and work with the healthcare systems all throughout the country and globe is you've got to have a philosophy, mission, and commitment to evidence-based practice. You've got to cultivate a culture where there is an ongoing spirit of inquiry. Very importantly, you've got to develop a critical mass of evidence-based practice mentors. Those are usually advanced practice nurses who not only have knowledge and skills in evidence-based practice, but also knowledge and skills in how to enhance organization and behavior change. A few years ago at our Ohio State healthcare system, we changed the job descriptions for clinical nurse specialists to be one of evidence-based practice mentors. The outcomes that have been achieved by that change have been extremely impactful. Our administrators, our directors, our nurse managers must walk the talk. If they are not leading by example, their staff will not do the same. If they are not supporting and providing the infrastructure that clinicians need to make this a consistent way of practice, it's also not going to sustain. Lastly, we must build in appreciation and recognition, and that has to be in the DNA of the system. More than money, people they want to be appreciated and recognized for their efforts. So if we want things to stick, we've got to recognize and appreciate folks. So my colleague, Ellen Feinelt, Overholt, and I developed this ARC model way back in the 90s. And we've got about 7 studies now that support the relationships in this model. And I think what's critical for everybody to see is that the key strategy in this ARC model is the use of evidence-based practice mentors, a critical mass of them within the healthcare system. Our studies have shown when these people are in place, clinicians' knowledge about evidence-based practice goes up, their beliefs about EBP go up, they implement more, and as a result of that, you see these wonderful so what outcomes, improvements in group cohesion, job satisfaction, decreases in intent to leave, higher quality of care, improved patient outcomes, and decrease costs. This is a publication that came out last year. Ellen and I worked with this Washington Hospital healthcare system in the San Francisco Bay Area. They implemented this ARC model. We skilled 102 evidence-based practice mentors across disciplines who then worked with their point of care staff on the consistent implementation of evidence-based practice. So what will the future of evidence-based practice look like? This is my dream. By 2030, so I've pushed it out 10 years, but if you look at paradigm shifts, they take decades to occur. The first time we said all nurses will be bachelor's prepared was in 1965. It is 2018, and there are still numerous states that have only a 35% baccalaureate prepared workforce. 100% of the healthcare decisions will be evidence-based. Reimbursement will only be provided for evidence-based practice. And of course, the dream is when we generate that research and we know it leads to positive outcomes, it's immediately translated into healthcare settings to improve care and outcomes. But what will it take to achieve that 2030 vision? Slaying of many sacred cows that still exist in healthcare systems all throughout the country. It will take interprofessional teams working together to advance EBP. It must have a sense of urgency. We know this leads to the best care, the best outcomes, the best safety. We must act with urgency to skill all our clinicians in evidence-based practice and to build cultures for evidence-based practice. We must get our professors and clinical educators all skilled and competent to teach evidence-based practice. Our leaders must walk the talk and invest in this. And then we've got to integrate these competencies as an expectation and standard of care. So I always ask this question in every evidence-based practice talk and workshop that I give. If I could be your fairy godmother in the next 2 to 5 years, what would you do if you know you couldn't fail? And now ask yourself, when I go back to take care of my patients, what is the smallest evidence-based practice change that I can make today or tomorrow that would have the largest positive impact for the people for whom you care? So my charge for you today is, what will you do in the next 90 days to further advance evidence-based practice, whether that's in academia or in the clinical settings? We have research that shows if people do not act within 90 days of attending some type of continuing education offering or a workshop, nothing is likely to happen. So we do have to keep dreaming big. We've got to get people excited about the dream. That is a real key to a leader's success. You can be a great strategic planning person, but if you can't get people to get enthusiastic about a great team dream, they're going to get tired. It's going to slow down. So you've got to find ways to keep people's dream out there about what EBP can do to help reach the quadruple aim. So some of you know it took 10 years to see this dream come to fruition. Over 10 years ago, I started pitching a dream for a National Institute of Evidence-Based Practice because we desperately needed one. Year after year, I would go to New York City to meet with the trustee for the Helene Fuld Health Trust. I kept pitching the dream. Finally, after 10 years, Marianne Caskren looked at me last summer and said, how much would it take for you to launch this new National Institute? I'm a competitive person. The largest gift that the Fuld had given to that point was $6 million, and I said $6.5 million. And it was music to my ears when she said, Bern, I think we can do that. So I went back down, did another presentation for her bosses, and last year we were funded with a $6.5 million gift to launch the National Fuld Institute for EBP. In October, I pulled leaders from over 40 national nursing and federal agencies together for an expert forum to make recommendations about what we need to do moving forward with the Fuld Institute and for advancing evidence-based practice. So it is a dream that came to fruition. Nothing happens unless first a dream. We've got to put our dreams out there. We've got to risk take through discovery, and we have to persist through the character builders until they come to fruition. We also have to eliminate these words because we've always done it that way, and I'm so thrilled to relate that the American Association of Specialty Boards in Nursing just gave us the first accreditation for evidence-based practice. So do stay tuned. We believe by September 1, you will be hearing from us that this is now available. So, certificate in evidence-based practice, the credential will be EBP-C, and we are very excited